Good evening. I'm David Levine. I'm co-chair of Science Writers in New York. Joseph Bonner, my co-chair, is running this and the tape, and also in charge of our website, and we'll be putting this on, recording this for YouTube station. Our guest tonight is Dr. Greg Vanichkachorn. And I will refer to you from now on as Dr. Van, as I was told.
Please.
And you're the medical director of the Mayo Clinic's COVID-19 Activity Rehabilitation Program.
Mm-hmm.
It was developed at Mayo Clinic in Rochester in June 2020 to care for patients experiencing persistent symptoms after COVID-19 infection. So this has many names. M.P.H refers to long-term COVID-19 symptoms as PASC, which stands for positive acute sequelae of SARS-CoV-2. You're probably more familiar with post-COVID syndrome, long COVID or long-term COVID, and people living with post-COVID syndrome are sometimes known as long haulers. So the first question I want to ask you is, what is, okay, and the other thing is that there's an article today that came out in PLOS One that's saying that 1/3 of all COVID patients will have long-term symptoms. So that's just published today. It's a good publication. So why don't you define long haulers and why you started the center for them and what you do for them?
Yeah, absolutely. So first of all, thank you so much for having me. So, the long haul COVID, as it's commonly referred to, is usually symptoms of really profound fatigue. And I think that's one of the hallmark features. And most people, when they hear the word fatigue, they think, okay, this is going to be like, having the flu or having a bad night of sleep. But it's really, really quite profound. So for example, a lot of patients, when we first started hearing about this, they would say things like they would go take their dog for a walk or take the trash out, and then they would have to take a nap for several hours or even be wiped out for a day or two. Quite distressful and really interrupts their lives. The other thing that we hear quite a bit about is shortness of breath. And that sort of makes sense to a lot of people because this is primarily a respiratory condition. That's really only the tip of the iceberg when it comes to what long haul COVID is, in my opinion. For example, we've got a lot of folks who present with neurological complaints. In fact, about 59% of our patients have neurological complaints, and that's about as common as the respiratory complaints. And that includes everything from like headaches, tingling and numbness in the arms, the feet, the legs, joint pains, dizziness, ringing in the ears. In addition, we also see a lot of cognitive complaints. So almost 45% of the patients that we see here have said they've had some troubles with word finding or troubles with multitasking or short-term memory. And that's very important to note because of all the things that I see in this condition, that's one of the most stressful because it comes up with problems at the workplace. Going back to your question of how did this all get started from? So I'm an occupational medicine and aerospace medicine doctor. The elephant always in the room is how in the world did I become sort of the face of taking care of long haul COVID here at Mayo Clinic? But my specialty had already been working with our ICU here to help patients coming out of the ICU get back on their feet and get back to work. And so it was only a matter of time before the pandemic went through that we saw our first patient coming out of the ICU with COVID-19. And I got to help that first patient and assess them and start helping them get back on their feet. And pretty much from the get-go, it was clear that these folks were not having the normal recovery that we anticipated. So I got together with many of my other colleagues here, from various specialties in pulmonary medicine, cardiology, infectious disease, rehab, and try to come up with a plan, like how do we help these people really get back? And as more and more patients came requesting help, the program became finalized in about June of 2020, which we call the COVID Activity Rehab Program, affectionately known as CARP here. I happen to be a fisherman, so that's where I got that name from. So the rest is history. And since then, we've been seeing maybe about 300 to 400 patients from across the country with this condition.
So for traditional COVID, how long does it usually last, and when do you cross over into long term?
So most of the research out there indicates that patients will get better with the acute COVID infection somewhere between 2 to 4 weeks. And so that's why we define as the start of long COVID as having symptoms that are continuing past that 4-week mark.
Okay, and does it always start? I mean, does people sometimes get better after 4 weeks, and then like a month or two down the road, they start getting relapses?
That's been a rarity. I've had a few
Okay.
patients mention that to me, but overall, patients tend to have more of a prolonged course that's consistent from the infection.
And and you said mostly it's respiratory. So so break it down to age groups. I mean, what are people who are senior citizens getting? What are children getting? What are middle-aged people getting? Is there differences?
Yeah, so
One thing I read that females get more long-term COVID than men.
yeah, great pickup there. So as for age groups, we are seeing a younger population in our patient population here at Mayo, the average age being about 45 or so. Normally, we would consider older individuals being at more risk for having an acute, severe reaction. And we sort of figured that these would be the same folks that would also have long haul COVID, but that's not what we're seeing. Again, it's a younger population that we're seeing. As for children under the age of 18, adolescents and so forth, I've seen a handful of patients in that age group. They tend to have very similar symptoms as the adults in our clinic. Fatigue, rashes, troubles with thinking as well too. As for the gender discrepancy, that is something that's been repeated both here at Mayo as well as in other clinics, and we're really not sure what to make of that at this point. It is totally possible and plausible that there could be some gender differences on a biological level that could explain that why people are having why there's a gender difference, excuse me. But it also could represent a socioeconomic difference as well too. Perhaps females are more likely to reach out to get assistance earlier on than males. Who knows? But definitely something that we need to look at more as we go forward. In fact, most of the research right now out there is really trying to figure out how this condition presents across different socioeconomic groups and genders. For example, I don't see many people like blue collar workers and so forth and males here in my clinic. And that may be who shows up here, but we don't know how this applies across the socioeconomic divide and across genders and ethnicities. So still trying to figure out how this is really looking.
Okay, so if you have questions, please put them in the Q&A box, and I will be very happy to read them in a few minutes. So again, the Q&A box. So the other question and actually I have a lot of questions, but
no problem.
What are the treatments for? How do you help people? And I guess also people are missing school if they're children, or they're missing work. And I imagine with symptoms like brain fog or memory problems or pain or dizziness, it's hard to work. It's hard to go back to school.
Yeah. So let me start with that last part about the functional aspect. That's something that we were very, very focused in on, especially as an occupational medicine division here. My role in medicine, my specialty, helps people with work-related health conditions or health conditions that affect their ability to work. So we honed in on that pretty quickly. And yes, we unfortunately do see that patients have very limited function because of this. So about a third of our patients had functional difficulties with just some of the basic activities of life, like taking a shower or using the bathroom, walking across your bedroom, those kinds of things. 80% had troubles with more of the routine type of things in life, like going grocery shopping, household chores, and work. About half of our patients, by the time they came to see us, were able to get back to work, but only about half of those were back to their normal work. Now that sounds kind of rosy, but the average time to presentation to our clinic was about 3 months for most of our patients. So if you think about it, many patients are having prolonged limitations with their ability to work for many months after their infection started. Same too for the children. Unfortunately, I've had several children be able to miss out on their schooling, as well as participating in many of their important activities like sports and so forth. This really is a condition where it can just really take your life away from you.
So how does it differ from, like, I once had a flu in my 20s and I felt awful for months. I just had zero energy. I took a shower and I go back to sleep.
Wow,
And,
interesting.
yeah.
Yeah,
So I never got tested for anything, but
yeah, this is a phenomenon that we have seen previously. It happened after the previous coronavirus outbreaks. There's also something called post-infectious fatigue syndrome, which may sounds very similar to what you're experiencing there too. And I think there are probably some similar aspects at play here. Of course, we've known about this kind of thing for decades, but there just hasn't been a lot of great research out there to understand what's going on at a chemical level. So it all kind of remains nebulous and unknown, unfortunately.
I just wanted to read one thing that I saw that, and just give me a second to find it. I started taking some pictures, screenshots, but so in the Wall Street Journal, psychiatrist Jeremy Devine suggests that many long-term symptoms may be psychologically generated or caused by physical illness unrelated to the prior infection. Devine proposed that long-term COVID is largely an invention of vocal patient activist groups. And that was also the point of the New Yorker article that we talked about earlier.
Yes. Yeah. This phenomenon that this is all in a patient's head has been around for a long time, and unfortunately has limited patients' ability to get care, I believe. In my opinion, there are two possibilities. One, there is a depression or anxiety or other similar mental health condition going on. But just because that's the case doesn't mean that there isn't also a physical or biochemical component going on as well too. And I tend to think that there's both at play here, that there's a mind-body connection. And yes, there may be an inflammatory or autoimmune process that's causing a lot of the symptoms that patients have. And patients may get depressed and anxious because of that. All of this that patients are experiencing doesn't happen in a bubble. Post-COVID syndrome is not just a bunch of symptoms. Everyone has all of these factors that limit or affect how they experience this illness. Some people have more psychosocial support than others. Some people have jobs that they can easily change. There is different financial support for individuals. So, we need to look at this as a psychosocial issue, but that doesn't mean that it's all a psychological issue. On top of that, I think there's some interesting research that has been coming out that's starting to shed a little bit more light on what some of the chemical processes are that are going on to lead to this condition. For example, I recently did a summary review of an article that came out from researchers in Arkansas that found the presence of autoantibodies against the angiotensin converting enzyme number 2, ACE2. And this is unique because these are the enzyme. This is the enzyme. ACE2 is the enzyme that the coronavirus uses to enter into our cells, and it is responsible, ACE2, for a lot of different things in our body. And if there is some form of impairment because of an autoimmune process or an antibody going on, well, that could have huge ramifications and would indicate that this is all just not a manifestation of depression, anxiety, or even something more subtle like a personality trait.
So I have some questions from the audience, and please feel free to send me more. Have you seen many cases of long haul COVID in the breakthrough infection category?
Okay, no. Now, so I started seeing patients who had breakthrough infections. And at first, okay, well, this is kind of two different answers here, but at first it was very exciting and I was concerned and I would, notify my colleagues in infectious disease. Now it's happening so frequently that it's not a surprise. But that being said, while I've helped patients recover from their acute infection and a breakthrough infection, I have not seen a lot of long COVID symptoms. Sometimes, they might have symptoms for like 5 or 6 weeks, but nothing long-term yet. Of course, it is very early on in sort of the Delta variant, or relatively early on in the Delta variant world. So time will tell, but I'm optimistic that I haven't seen many cases after the breakthrough.
Well, in the CDC guidelines, they say that the best way to prevent getting long-term COVID is to be vaccinated.
Correct.
And I guess that's true.
Mhm.
Another question is, are you familiar with research by Dr. Bruce Patterson, formerly of Stanford, about the biomarkers of long haul and the role of the S1 protein? Is this consistent with what you at the Mayo Clinic have found?
Yeah, Dr. Patterson, I'm not familiar with that work specifically, and I know they have a very robust program out there. So I can't comment on that. We have not gone after the S1 protein here, but we have a lot of specialists in the immunology, infectious disease, rheumatology area, all looking at this and trying to figure it out together. And I'm grateful that we have other outside minds also contributing to this science. So not familiar off the top of my head.
What is the S1 protein?
I'm also not familiar off the top of my head, I'll be honest with you. It only fits so much in here.
Okay. And is there an autoimmune component of long-term COVID?
Yeah, well, I think there is certainly. We see a lot of patients with like neuropathy that is new. There are markers of inflammation that are ongoing. And then, of course, just like the study I mentioned, the autoantibodies against ACE2. So I do think that there is some form of autoimmune abnormality. We just haven't really got a good idea of what exactly it is, and definitely don't know what to call it.
So, in the CDCs, they said what causes symptoms in the long haulers, and they said that the virus can attack the body in a range of ways, causing damage to the lungs, heart, nervous system, kidneys, liver, and other organs. Mental health problems can arise from grief and loss, unresolved pain or fatigue, or from post-traumatic disorder, PTSD, after treatment in the ICU. So in terms of damage to the lungs and heart, nervous system, these are not respiratory symptoms.
Right.
But you're seeing that, right?
Correct. Yeah. The more I look at this condition from a long haul lens, it looks more to be a neurological and respiratory condition versus just a respiratory condition. Maybe even a cardiovascular condition too. We see patients who've had difficulties with like myocarditis after their infection, so that definitely can occur. But we see quite a number of patients with strange neurological symptoms, tinnitus, ringing in the ears. That's brand new, sometimes associated with complete loss of hearing, objectively on testing too. That's a difficult one to explain, but we think that's related to neuropathy. We also see a fair amount of autonomic dysfunction as well too. And I can talk more about that if you like here. But yeah, it's not just a condition that affects the lungs. Now, as for lungs and lung symptoms, so yes, we have seen in the previous coronavirus infections that individuals can have a long-term shortness of breath, sometimes several months to a year after the infection, and not have everything else. And so, we think this is happening because there is dysfunction in how the lungs are moving, as well as possible scarring or fibrosis of the lung tissue.
And these are not things that you would see in a typical flu.
Correct. Right.
So very different. And what about past, coronaviruses? Were those seen or not?
Yes. So we have seen long-term difficulties with breathing, all slowly improving, but long-term difficulties after the SARS and MERS outbreaks.
Okay, which were much
smaller scale, yeah.
Lower scale, and also kind of went away. Here's a question: what is your treatment for COVID-19 long hauler symptoms? Do you have success factors with a specific treatment?
Okay, yeah. So we don't have any outcome studies yet, formal outcome studies, but we do have some inferences and observations that we've made in our own patient population. We are planning to do a clinical trial here soon, so we'll have more in-depth information. But that being said, so I guess I'll start with the treatment first. That probably makes sense. So the treatment that we do is pretty much 5 different buckets. The first one is making sure that nothing else is going on that could explain a patient's symptoms, especially anything life-threatening. like a blood clot or heart disease or something like that, or another infection, an opportunistic infection. So we rule that stuff out first. We do occasionally find some things that are concerning. We get those patients into additional treatment. The next up is psychosocial support. Now, I want to be very, very careful to say that this is not just some sort of forced counseling or telling everyone that it's all in their head or anything like that. But what we mean by this is, patients are so stressed when they come to us. They've been told so many unhelpful things like, we can't help you. This is all in your head. Some of the worst ones are, you just need to tough it up and get with it. So patients often come to us with a lot of self-doubt and guilt, and frankly, they think this is all in their head and they're crazy. So we validate patients and talk to them, let them know that they're not alone in this condition, which can be very rewarding for patients. The next up is rehab. And this component is helping people recondition, because we know for a fact that patients can be extremely deconditioned after the COVID infection. I mean, you can be deconditioned on any infection, including a sinus infection, even if it's just for a few days, but COVID really seemed to take a wallop to people. With that being said, what we don't want people to do is exercise their way out of this. In fact, we've seen people get worse with exercise. And I have some very accomplished athletes who have come down with this, marathon runners and so forth. And they try to get back to running 10 miles and they can do it. And then they feel down and out for like a week or two afterwards. So we recommend more of a slow paced activity, including just daily activities like, doing household chores and dishes and mowing the lawn as part of the rehabilitation process. That takes a very hands-on approach because patients don't like to slow down. We find everyone's so eager to get back to their lives. So it takes a lot of walking with the patient for this. And then, of course, as I mentioned earlier, we see a lot of autonomic dysfunction. So we aim at treatments for that, as well as helping patients recover from brain fog using a strategy that's similar to treating concussions and post-concussion syndrome. Okay, so now that I got that out there, so what kind of things work? Well, one of the overall strategies that we have is that we want to minimize patient symptoms as much as possible so they can get back to the rehabilitation part and slowly increase their activity. So we'll often try medicines that can help with, for example, neuropathy, things that help with headache. There are strategies to help with autonomic dysfunction. So, for example, if people are feeling dizzy and so forth. A lot of patients will suffer from rapid heart rate. So sometimes we use medications for that as well. And all of that comes together to allow the patients to slowly increase their activity. And what we have found is that patients who are able to get treatment sooner, say about 5 weeks out from their infection, they tend to be the ones that get better somewhere between about 4 to 6 months. We also find that patients that have less cognitive complaints at the very beginning to be the ones that get better faster. So those are some of the prognostic factors. But right now, when we look back at our first 100 patients that we had seen at Mayo Clinic, about 20% of those patients were able to make a full recovery in about 4 to 6 months. And when I say full recovery, they went from not being able to do anything like, even walk across their home to be able to get back to full duty work, sometimes even laborious work. Now, outside of that group, there does tend to be a group right now that is lingering more so. And I have some patients, unfortunately, now who are a year or more out from their infection. They all have been doing better. So I'm happy to say that. But it does look like for these folks, until we come up with something new, that this is a truly long haul condition and perhaps even chronic.
Yeah, ironically, one of the doctors I see, his resident was on 60 Minutes, and she talked about it, and I tried to get her to come on, and she said, I can't even sit up for an hour.
Oh my gosh.
And she's actually a rehab doctor.
Oh, wow. Yeah. Well, there you go.
Yeah.
There you go.
So someone asked, can you talk more about autonomic dysfunction and the exact treatment of brain fog?
Okay. Yeah. So great question. Autonomic dysfunction. Let's just briefly review. The autonomic nervous system is the part of our nervous system that takes care of all the stuff that we normally don't pay attention to. So that would be things like, our GI system moving, our blood pressure and heart rate changing depending on our body position, sweating, believe it or not. Also our fight and flight response, which is important to note. And there can be problems with this system. And for example, sorry, let me go back. And so if there is a problem with the system, it can lead to a wide variety of symptoms like fatigue or exercise intolerance or headaches, dizziness. And if those all sound very familiar, that's not a coincidence, we feel. We have seen autonomic dysfunction occur after SARS and MERS. We have reports of autonomic dysfunction already in COVID-19, including in our own patient population. We did do a study that came out about that a couple of months ago as well, too. And so we think that there's a lot of autonomic dysfunction at play here. And this autonomic dysfunction may be occurring because of an autoimmune process, either inflammation affecting the nerves, or even possibly an antibody situation. It's not too far-fetched. I mean, we do have studies that show that, for example, in the brain tissue, there was lots of immune cells after COVID-19. We also have indications that there's increased inflammation in the fluid that's around the spinal column and the brain, something called interleukin-6. So we have a way to explain it, how this may be happening after the infection. One of the most difficult aspects about that, though, is getting the evaluation and diagnosis of it. We're very fortunate here at Mayo to have all the facilities that we would need to do that. But, and this is not some sort of, marketing thing, but it does take quite a bit of know-how to do this. And the test is often called an autonomic reflex test, where we first measure the changes in heart rate and blood pressure depending on someone's position on a table. We also measure sweat function either by giving a little bit of stimulus or doing this really fun test called a thermoregulatory sweat test. I'll let you read more about it, but it's called the Smurf test. And there also going to be a biopsy of the skin too, looking for some nerve changes. Once we have all that information, we'll typically get patients evaluated by our autonomic neurology clinic. So these are neurologists that specialize in autonomic dysfunction, and then we can start the treatment program. Fortunately, the first step in treatment for this is conservative measures. One form of autonomic dysfunction that many folks may have heard about is something called POTS, which is postural tachycardia syndrome. And that's been described after COVID-19 as well as other viral infections. Dizziness is one of the hallmark signs of this. So conservative treatment usually begins with like fluid hydration, making sure you have actually adequate salt intake. Now, when's the last time you heard a doctor say get more salt, right? But we sometimes say, get a Gatorade in during the day or have an extra piece of bacon or things like that. I mean, you don't want to do this if your blood pressure is skyrocketing through the roof, but it's not a good time to be cutting back on those kinds of things. We also recommend things like compression stockings or even abdominal binders. And there's a couple of different body position strategies that we also teach. And this is all done through an educational program here that we enroll patients in, and that's been very well received. If there are more measures that need to be done because patients aren't responding fully, there are some medications that can be used. So for example, we'll sometimes try what's called neuroleptic medications like gabapentin or Lyrica. We also could use medications, for example, to either drop the heart rate, like beta blockers, or medications to bump up blood pressure if that's an issue. So there's a wide variety of things. It's just, it takes an open mind, an unbiased mind to first acknowledge that this is a possibility, a place to get the diagnostic testing, and then a place that's willing to do the treatment, which has often been a barrier for folks.
Okay. So they also talk about there's been kidney damage and also the loss of senses of smell and taste. That's a very common symptom. I know I had a friend who had COVID for a couple of days. He lost his sense of smell and then it just came back. Is that something that can linger around also?
Yes, unfortunately, we have seen individuals who have had prolonged difficulties with taste and smell, somewhere between 6 to 10 months. The good news is that I haven't seen anybody stay that way. They slowly seem to improve over time. There are a couple of things that people are trying and we're recommending here for that. For example, there is this thing called olfactory retraining, which involves smelling a couple of different fragrances and helping retrain the system. There's a couple of supplements that also have been recommended for that, like fish oil. So there are treatments that can be done for this, but fortunately, people do seem to get that back. The importance of it, though, can't be underestimated, because one of the things we also see is folks having difficulties with nutrition because they're not wanting to really eat anything after their infection, and that can be very limiting.
Okay. Another question, since antibodies are present in some with long COVID, do you think it might be worthwhile to conduct trials of drugs that target the autoantibodies? And do you think autoimmunity might explain the female preponderance of long COVID?
Mm-hmm. All possible, yes, I would say so. And I totally hear you about the clinical trials question here. Right now, again, we are still in the early stages of this condition, understanding it. Many of you may have heard about the funding that was out there recently by the M.P.H to look at this condition, millions of dollars. But all of that funding, the primary purpose was, again, to see how this condition presents across the population. The next phase will be the clinical trial stage, where we can consider possible drugs to treat autoimmunity, things like IVIG and so forth. But we're not there yet, and everyone is sort of, kind of getting their groups together and their teams together to take this on, including here at Mayo. But right now, we just don't have those clinical trials in progress. But I do want people to be hopeful. I think once we start doing that, that'll be a great step forward and give us some better ways to treat people other than the rehab process.
So by the time a person gets to you, how many doctors have they usually seen?
Anywhere from none to 5 or 6, unfortunately. And it's easy to see how this would happen. As I often tell folks, this is a condition that's not well understood by patients and not well understood about providers. One of our primary goals here at Mayo has been to develop programs to help other providers get education about this, because you don't have to come to a place like Mayo Clinic to get care for this condition. All it takes is a properly trained primary care provider and the necessary resources for people to be able to get care for this in their community. And that's where we hope this will eventually go to, that people will be able to have much better access to the care.
Okay. CDC also says that one study showed that 60% of people who recovered from COVID-19 had signs of ongoing heart inflammation, which could lead to the common symptoms of shortness of breath, palpitations, and rapid heartbeat. Now, in the New Yorker article, you mentioned, I think it's called POTS.
Mm-hmm. Mm-hmm.
That there's one doctor who was convinced that it was totally nonsense, and he did a trial where he switched things around and things, and then he said, "Well, actually, it's real." But he didn't think it was. He thought it was all psychological.
Yeah.
And so that's very, very interesting. Are there more people having long-term COVID now? Because we've had, a lot of people infected in this country.
Yeah.
And around the world. Are you, when you speak to colleagues around the world, are they seeing the same symptoms also?
Yes. I think there are more people finally who are able to get care about this, so we're seeing it more often. And one of the first barriers was just getting providers to see these individuals and listen to the patient's complaints. So now I think we're getting over that hurdle for the most part. As you said, there's a lot of skeptics out there still about this condition. And so now the numbers are increasing. And then of course we have the Delta variant now coming through here, and only time will tell how that's going to change the numbers.
Well, I think the Delta variant seems to be decreasing in some areas.
Yes. Yeah. I feel like I'm waiting with bated breath, holding my breath for a long time to see what happens. Every day is different depending on the information, but I do take it very seriously. And, I think that patients should continue to protect themselves and do all of those things that we've learned to do over the last year or so.
Okay. How do you advise parents to help, children complain about, I mean, they can't do pain scales with children because they're just, 1 to 10 doesn't work. It's like, what hurt? How do you feel? 10,
Yeah.
I'm in pain, and so how do parents, what should they be doing to help their children?
I think it's the same thing that I would tell adults about this as well too. And that's in this condition, which is so new, we all need to have an open mind.
Okay.
And of course, parents know the nuances of their children better than anybody else. And so, yes, there's some kids who are more complainers and not. I've got 4 kids of my own, so I totally know how it goes. But I think erring on the side of being open-minded is really important in this condition. Until we have a better understanding of what this is and what's going on a chemical level, it's going to be really hard for anybody to say what is or is not related to COVID or long haul COVID.
So Chris Cuomo famously posted on, I don't know what he posted on YouTube, Instagram, that he had COVID and he said, you got to fight it. You got to do exercises at home. And I watched this, I said, if you're really sick, you don't feel like you shouldn't be doing exercises at home. You shouldn't be, trying to raise your heart rate. And like you mentioned that people are, marathon runners are, trying to do running.
Yeah.
I had some of my number 1 tennis player said, I hope I do okay tonight. 103 yesterday. I said, you're not going to do okay. I said, well, the fever's gone. I said, yeah, but you're tired. You're still sick. And he did, and after 3 games, he quit, so there's that, I guess there's that optimism that people have that they're getting better and that they can just resume their life. And you're telling people kind of to slow down.
Yeah, which is a really hard pill for a lot of folks to swallow. I will say that some of the more difficult cases have been our more successful individuals and individuals who have been able to really get through and be successful in life by just really gritting their teeth and push through things, But yeah, it comes to a point where the no pain, no gain strategy and exercise can really do more harm than good. And I'm a big proponent of exercise. It's been crucial for my patients and I counsel them quite a bit. But in this scenario, yeah, you can't just hit the treadmill and run out of long COVID.
Okay. So should people be walking, just doing baby steps and that kind of stuff?
Yeah, baby steps. And so what I remind folks is that rehab doesn't just occur via exercises. In fact, I try to avoid that exercise word altogether. So yeah, we have patients do exercise rehab activities like yoga, or maybe riding on a stationary bike or so forth, or some light weights. But another part of that also is all of those things you do during the day that are important for your daily function in life. So again, doing the household chores and all those kinds of things, doing those kinds of things that needs to be included in your pacing. So, if you repaint your home on the inside one day, you probably don't need to add in extra exercises on top of that as part of your long COVID experience. So it's important to pace both physically and mentally as well. I'll have patients who say, well, okay, I listened to you, doc. So I didn't do any physical activity, but I decided to finally write that book that I wanted to do. And I still feel terrible. I'm like, well, what do you mean when you started to write a book? I was like, well, I just stayed on my computer for like 12 hours and typed. That's not good pacing either. So a lot of people forget about those nuances there.
Okay, I have another question. Have you found that patients with long-term COVID are particularly vulnerable to misinformation about their condition? How can they be protected from charlatans? Now, I want to mention that in the New Yorker article, there's one of the experts, it's basically a large Facebook group of patient advocates, but she's not an expert. But she's testifying before the NIH and Congress and all these things, but she got long-term COVID. And although it's admirable, I mean, there are patients like Michael J. Fox who've done great things. Mm-hmm. I just think, but these people aren't experts. And I do worry that they're telling people things that aren't always true, or else just telling things that, from their experience.
Yeah, no, that's a great point. I first of all have nothing but respect for the support groups. They were very instrumental, especially early on, in helping raise awareness about this issue, and they continue to provide some great support for patients who are suffering this. But at the same time, yeah, I have seen out there where there's some questionable treatments being recommended. And what I like to remind folks is that if anyone really feels like they have the answer to this and it's all figured out, that's not a good sign. And I